Thank you very much. So welcome everybody to today's webinar, which is the launch of the Deterioration of the Newborn Framework for Practice, and that incorporates the updated Newborn Early Warning Track and Trigger Chart, effectively known as NEWTT2. So my name is Dr. Wendy Tyler, and I'm a chair of the working group for the Deterioration of the Newborn, and I have a co-chair that you'll meet later on in the meeting called Dr. Kathryn Macallister. So this is why we're here today, and this is what the framework is about. This is a newborn term baby who is transitioning in the safety of his or her parents, having skin-to-skin and thermal care. But what we don't know is whether he or she will fully transition, or whether the baby will show signs of disordered or delayed transition, or indeed whether this baby is at risk of serious illness and in an at-risk group. And this is what we're trying to address, so that we could try and detect illness early and give treatment as soon as possible. We've developed the framework in conjunction with the Maternity and Neonatal NEWTT teams, and it's been a fabulous alliance. And in order to do so, we've based the framework on their PAIR framework. And that is so that we can have a uniform, standardised approach to planning for babies, so knowing which babies are at risk, a uniform identification with an updated, evolved NEWTT2 chart, and then a standardised escalation when a baby triggers, and a standard multidisciplinary team response. There are a number of resources which are now available on the website, including the NEWTT2 chart itself on the front, and then with the escalation tools on the back, and a joint escalation and review record, and my colleagues are going to take you through these in due course. There are additional resources, including an appendix, Appendix 1, which is a summary of the newborns who are currently at risk to be used the NEWTT2 monitoring. There's Appendix 2, which is a guidance for us as healthcare professionals to assist with completion of the NEWTT2 chart. And then there will be training materials that have been developed, which in terms of a slide set. This webinar will be freely available, and Health Education England have asked us to contribute to an e-learning, so to watch this space. Furthermore, there is an Appendix 7, which is actually a survey, the results of the survey that were run by the working group, and which hopefully many of you on the call actually contributed to. And the results of that are available as Appendix 7 on the website. So this is the working group, and we met just before the pandemic hit, and so I have to thank them all for their commitment and enthusiasm over the last 2 years. There is no time, unfortunately, for me to actually match all their names on the left-hand side with their lovely smiling faces on the right. But I just particularly at this point want to point out to you Dr. Kathryn Macallister on the top left-hand corner, who is my co-chair, and on the bottom left-hand corner, both Beth and Kelly, who are parent representatives who graciously assisted us with their time. So without further ado, this is the webinar programme. I'm about to spend a few minutes explaining which babies the new tools are for. And then I'll hand over to Dr. John Madar, who's a consultant neonatologist at the University of Plymouth Hospitals, and he will take you through the front of the NEWTT2 chart and highlighting tracking, and pass over then to Dr. Oliver Rackham, who's a consultant neonatologist in North Wales, who would describe to you how we're using the Escalation tool. Dr. Kathryn Macallister, who is a neonatal grid trainee and as recently was the trainee representative on the British Association of Perinatal Medicine Executive Committee, will take you through the combined response tools. And then we will hand over to our NEWTT team. So we have with us today Mrs. Hannah Rutter, who is a midwife and senior improvement manager, who's going to take you through about 1.5 years of testing that the NEWTT team have done for us with their teams. And then finally, Tony Kelly is joining us, and so we can discuss perhaps next steps, the future of digitalisation and evaluating the success of this tool. And then at the end, there's a question and answer. So Kathryn and myself will hopefully host a question and answer session. So what we ask for you is to write your questions and comments in the chat, please. If able to, when we get to the question and answer session, we'll have all the panel members present, and it may be that you can ask a question directly. And if we do get to be able to do that, when you ask a question, if you could kindly put your camera on and your hand up and your camera on, that'd be really helpful. Thank you. So without further ado, we'll move on to the programme. So these new tools, which babies are they for? Well, in short, they're for babies on postnatal ward settings. So that means postnatal ward, transitional care, or even delivery suite if the baby is still remaining there for some reason. And it's for term or late preterm infants. The paediatric teams that are involved in the development of PEWs were very keen for us to reinforce that these tools are not for use on a paediatric ward. Children that are admitted to paediatric ward are admitted because they are unwell, and therefore their early warning scores are focused on different aspects. It's also not really for use on a neonatal unit, and that's because on a neonatal unit there are babies admitted there with very varying gestational age ranges and likely very different physiological value ranges. So before we get into the at-risk groups, the framework also addresses observations and assessments for every newborn. Where possible, we've aligned with national guidance. So, for example, you need to follow the recommendations for recording observations that are consistent with the NICE postnatal and intrapartum care and the Resus Council. But we'd encourage healthcare professionals before the baby is born to identify if the baby fulfills any risk factors, which we'll come to next. There's the initial examination and the measurement of temperature that every baby should have, and the temperature should be measured until it is within the normal range. We have supported the recommendations from HSIB for monitoring during the skin-to-skin contact, and also point you towards the UNICEF guidance for monitoring feeding and excretion. And lastly, supporting the NICE guidance for jaundice, is that obviously every baby needs to be monitored for jaundice, and we would encourage people to use the NICE gestational age specific charts to be able to monitor and track and trigger using the NICE jaundice charts. It's probably important here just to say that when we're assessing for jaundice, we need to look not just at skin colour, and it's very important that we also look at the whites of the eyes, the sclera, and other parts of the baby, such as the gums, to be able to detect jaundice in darker-skinned infants promptly. So moving on to the at-risk groups, these have been separated into 7 main sections. The first one we have is intrapartum. So any baby that has been born that's had evidence of fetal compromise or meconium-stained amniotic fluid should be entered on observations onto the NEWTT2 charts. And the main framework gives advice on the frequency and duration of monitoring, and where at all possible, we have aligned with existing national guidance. Where this has not been made available, a consensus opinion has been given that monitoring should be every 4 hours, but this actually, it can be determined locally, and it may be that an individual baby needs to have an individual plan made about the frequency and duration of monitoring. Elective pre-labour caesarean section less than 39 weeks gestation has been shown and to lead to increased admission to a neonatal unit due to it retained lung fluid, and therefore it is advised that these babies are monitored on the NEWTT2 chart, as are unplanned out-of-hospital births. We've aligned with the monitoring recommended by NICE for risk factors or clinical indicators for babies at risk of early onset infection, and we've extended this to include monitoring for babies on treatment. We've also sought to align with the BAPM framework for monitoring for babies with hypoglycemia risk and transitional care. Postnatal concerns did worry us, and we'd be very keen for people to initiate the NEWTT2 chart and the other tools should they have any concerns about a baby. So that might include early jaundice and particularly persistent or especially new onset grunting. So grunting after a period where there's been no grunting can often be a sign of sepsis. Altered tone and feeding issues or behaviour change. And the HSIB report shared that feeding issues, including reluctance, refusal, or particularly any deterioration of feeding, are often the first sign of group streptococcal sepsis. Lastly, maternal medications. So babies who've been exposed to opiates less than 6 hours prior to birth or psychotropics could have this chart used for their monitoring, and the psychotropics is recommended by a NICE guidance. We also would like to offer the chart to be used for consideration of use for those babies who've been exposed to prescribed or illicit maternal drug use if no other chart is available. To support you in the main framework, there is a table 2, which gives more detail for each of these 7 areas with references and guidance as to frequency and duration where this is available. And as I've said already, there is a summary for this in Appendix 1. And the idea of having it in 2 places was in case the delivery suites or postnatal wards wanted to print out the first appendix and have it up on a board somewhere as a reminder when they're admitting babies to their area. So the support for the at-risk groups was through a wide literature search, and as I said, aligning with national guidance that already exists. It is also a consensus opinion, and there was also a survey, which I'll just mention briefly in a moment, which I'm hoping most of you contributed to on the call. So I want to thank at this point Dr. Shalini Oja. I hope she's with us. And Shalini and Kathryn initially ran a scoping survey looking to see who was using NEWTT, the NEWTT that was developed in 2015. And actually quite a lot of units in the UK were using NEWTT, although a number of them said that they had modified it. So that led us to think, well, actually, we really would quite like to know why the NEWTT chart was modified and how we can incorporate those essential thoughts and opinions into NEWTT2. So Shalini ran a qualitative and quantitative survey, which was extremely successful with multidisciplinary inputs, and has published that in the Infant Journal and also as a letter in archives, which has been online for some months, but is actually in the current paper journal this month. So moving on now, I want to introduce you to our case for today called Matthew. So Matthew is going to appear through the next 2 presentations, and Matthew is going to demonstrate, hopefully, how we feel that the tools will be used in practice. So Matthew was born at 35 plus 6 weeks gestation. He had a birth weight of 2.32 kilograms. That made him a transitional care baby, so he already warrants being plotted on the NEWTT2 chart for that reason. But he's had his skin and he latched early at the breast, but then he became very quiet and he's not waking for feeds. So he has another reason to be monitored on the NEWTT2 chart, and that is postnatal concerns. So without further ado, I'm going to hand over now to Dr. John Madar. I was going to take you through the NEWTT2 chart itself. I want to introduce John especially because John was one of the group that developed the first ever published worldwide original early warning score in the newborn, called the News UK Plymouth. So it's, without embarrassing you any further, I'm going to hand over to you, John, and thanks ever so much for everything.
Thanks, Wendy. You bigged me up. Now I've got to live up to expectations. So we'll start by just sharing a screen and hopefully a presentation. First of all, you've got to find your mouse. And with a bit of luck, you should be able to see that. So I'm going to talk in the next few minutes just about the chart and the domains in the chart and how the scoring system works. Then we'll apply it to Matthew to see what his score is, and then I'll hand over to Oliver, who will take you through how that then applies in terms of what happens next. So the chart itself has evolved. The chart on the left here is very familiar to people. This is the current NEWTT chart, which evolved, as Wendy has said, from something we developed down here, and that's been running for some years. And then, because of various aspects of that chart and the thinking around that chart, it's evolved, and the new chart, NEWTT2, is the chart on the right, and this is what we'll be talking about today. And it's very much evolution rather than revolution in terms of the chart. It looks different, but actually the domains and many of the areas are very similar. So if we look at the chart, and the chart here is in the centre, and we concentrate just on 1 or 2 elements, we can see that the domains are a different colour, but they are still graded in white, pale yellow, pink, and then we have a new domain in purple here, which I'll come on to. So for the main domains of white, yellow and red, we actually score these, and white scores 0, yellow is 1, 2. So these are escalations, and the scores are prompted by the central spine, which just reminds people of what score applied to which colour. And those are the scores that you would then acknowledge for the different domains of temperature, breathing, heart rate, and so on and so forth. The purple box was a prompt which recognised that there are certain critical observations which mean that we need to escalate immediately. So, for example, extremely slow breathing, extreme bradycardia, and so on. So these purple boxes, if these are triggered, that is a trigger for an immediate escalation, irrespective of any other aspects on the chart. Another new innovation is a pale blue line, and that's in the temperature box. And this is just to acknowledge mild hypothermia. And again, it's an immediate prompt to say, do something about it. If you score blue in the temperature zone, escalate in that respect. So in terms of the domains in the chart, temperature, breathing, with grunting as an indication of increased effort, heart rate, colour, saturations, neurology, there are guidances in the appendix which define what it is that's measured and guidances on how to actually define those observations. So if we then break the chart down and look at each area of the chart, at the top of the chart, it's just information on the patient, but also on who is initiating the scoring on this particular instance and the reason why they are being observed, with some recommendations as to the frequency. So these are meant to be completed when the chart is started, giving some accountability as to why it exists. And then there are date time boxes for each time a set of observations is taken. Moving down, we have temperature, again, degrees C, and we have a normal zone and then escalation in getting warm and in cooling with that blue prompt there. And the blue box is the box to prompt that the baby warms up. So you plot the temperature and you score 0 for white, 1 for yellow, or in this case blue, and 2 for the pink, and that's the score that you acknowledge. Breathing, very much the same, plot the respiratory rate in breaths per minute. Also, whether or not there's evidence of grunting, which gives you an extra weighting on that score. Note the colour, note the score. And again, if you're breathing very slowly, that's immediate escalation with a medical review, as for any critical observation in purple. Heart rate, again, very similar. If you're in the white zone, that's okay. And you score 0. If your heart rate is in the yellow zone, it's getting a little bit worrying. And then there are escalations into the pink for very high and low rates. And again, a purple zone there for very slow heart rates, which is immediate escalation. There are other observations, and these are colour and or saturations, some observations on the neurological state, feeding, glucose, and this thing here, the carer observations, which again is we'll come on to in a minute. So we plot those in a very similar way, and they're graded in terms of sort of white, yellow, or pink response. But again, there are purple responses for unrousable floppy babies, for very low saturations and for very low sugars, which say do something now. Parental concern is new, reflecting Ockenden and a need to acknowledge that care is shared between parents and carers and the staff on the ward. So if there is parental concern, that again is acknowledged and will weight the chart towards action if there's parental concern. And parental concern needs to be actively sought. Questions should be asked which seek to clarify whether a parent is concerned or not, because some may not express that concern unless you actually ask them. And the scoring at the bottom, again, you score down the chart, adding up the scores, and that gives you a total for that particular time. And that will then define whether or not there is an escalation and initials for accountability. So in summary, we've got graded scoring, no different to now, with a number of domains. We have the purple box for immediate escalation. We have the blue box to prompt thermal care. And we have parental carer concern as a new domain. And apart from that, the chart functions in a way which allows you to stratify concern in the different domains. So if we take this and apply it to Matthew, as we've heard, is 35 plus 6 weeks gestation. He's 2.32 kilograms. He has skin to skin. He latched early, but he's quiet and not waking for feeds. So if we apply that to Matthew, what we've got temperature measured at 36.2. So if we look at the chart, here we are, 36.2. That plots just into the blue, so that's a 1. We've got a respiratory rate of 44. If we look at the chart, that's here. If we magnify it, that's still in the white. That scores 0. There's no grunting, so we don't score for grunting. The heart rate is 162. We plot that on the chart. We look at it. We see that's just into the yellow, so that's a 1. Saturation is 96. We've measured that and we've recorded it, and it's here. That's within the white zone, so that's a 0. He's got a little bit of poor tone. So poor tone is scoring in the yellow zone, so that's 1. He's not feeding. Not feeding is of concern. That's a 2. There is some parental concern, so that's going to give us a 1. And the glucose is 1.6, and that scores here. So that's another concern. That's 2. So if we add this up, we have a score of 8, which suggests that there is something going on which needs action, and that's escalation. So I'm going to hand over now to Oliver, who will take you through escalation. So thank you very much.
Thanks very much, John. So yeah, I'll just get the slides up. Okay, thanks. So I'm Oliver Rackham. I'm one of the neonatal consultants in Clwyd in North Wales. I'm part of the working group. Thanks very much for the opportunity to speak today about the escalation section of the NEWTT2 chart. So as Wendy's explained, this is part of the peer framework, and this symbol you see at the top shows the purpose of the escalation, where it fits into the process. It's based on the peer framework for planning, preparing and preventing, and then identification, and then we move on to escalation. It's been adopted by the National Patient Safety Programme. The aim of this is that we have a standardised way of escalating, and that it's timely. So they're the 2 key bits to the escalation that we wanted to do, and that we appropriately involve the multidisciplinary team to provide the safest possible patient care. We also, as John has pointed out, want to make sure we involve parents and their families, and to keep the shared responsibility of the whole team. So this means even though there's escalation, as John said, when things are picked up,
in a way that, excluded from the sample, potentially.
Sorry, I think someone's just got a microphone on. If you're able to turn off, thanks. That the responsibility stays with the team, and just calling someone doesn't absolve you of any of your responsibility, and you need to continue to take action. So what's new in NEWTT2? Well, the aim of the working group really was for us to produce a standardised pathway, and the feeling of people within the working group was that there's unwarranted variation, and that's both in who reviews babies and to what timescales that might be done according to. There isn't any randomised control evidence for any of this, and so the standards that have been reached are done by consensus based on expert practice and by surveys of users. This means that one of our next steps, which Tony is going to speak about later, is data collection, looking into the efficacy and usability of the tool. That's going to be crucial moving forward to be sure that these changes we've made are providing good care and improving the care we're providing. So as part of NEWTT2, as well as the chart which John has already shown, we have some decision support tools which provide guidance about to whom concerns should be raised and in what timescales the baby should be reviewed. We've also, as Wendy initially mentioned, produced some escalation records, which are there to help people in their recording of actions. And these are in a format that could easily be used in a paper record, but equally can be very easily adapted for electronic patient records where they exist. So what is the escalation process? Well, we've already seen the NEWTT2 track and trigger observation chart style tool in John's presentation there. And on the back are the instructions, and with that, the thresholds and triggers for escalation for any given score. This is in a tabular form, which is in keeping with most of the early warning systems used in the UK. It's color-coded to aid decision-making and communication, and has hopefully been designed to be easily readable by all, with colours that make sense to everybody. And now what I'll do is zoom in on that and look at each section a little bit more closely over the next few slides. So at the top of the page are the instructions for use. The score generated advises on the level and urgency of the escalation that you need. Regardless of the score, a healthcare professional can always request a review based on their clinical concerns. This may be largely due to parental concern and remains a crucial part of clinical care. We don't want people to act solely on a number. We need them to be making sure they're looking after the babies in front of them. So if the score is 0, then observations continue at the frequency you've previously agreed. As Wendy said, that the kind of default is set at 4 hours, but will need to be adapted for individual use and maybe different in different units. When we then come down to the table itself, which shows the thresholds and triggers. On the left there, you'll see we've got a kind of nice yellow and then a worse yellow. So score of 1 should alert the healthcare professional to low-level concerns. They should inform the shift leader and consider whether any other investigations, such as an oxygen saturation reading or a blood glucose, are required. Those actions that are in that white row apply to all the subsequent higher scores from now on. Following on from score of 1, there should be repeated observation within an hour. If the score is now 0, then the routine observations can continue. And if the score remains 1, then escalation should be as for a score of 2 or 3. Remember there that in all of these cases, whatever the score, you must take steps to manage and address any of those obvious concerns or problems. If the score is 2 or 3, then this triggers escalation to the Tier 1 doctor or ANMP, which should occur within 1 hour. For a score of 4 to 5, this review should be within 15 minutes. Obviously, different organisations will have a different skill mix, and the exact member of the team to whom concerns are escalated may need to be adapted. The generic term of Tier 1 has been used as this is terminology that should be being used everywhere, even if people do refer to different people in other ways. And it might be that you have different teams of people on, and that may vary between your hospitals. If you have a score of 6 or more, an immediate review by the Tier 1 doctor or ANMP should be requested, and at that point the Tier 2 doctor or ANMP should also be informed, although you may not feel they need to attend at that time. As John pointed out, any observations in the purple critical zone, so these are things like a baby with a respiratory rate less than 20, a heart rate less than 60, or a baby who's unrousable, require an immediate review by the Tier 1 and the Tier 2 doctor or ANMP. The reason both are needed is you often need more than one pair of hands, and also we felt it's very important that the Tier 1 doctors are included in the management of these, because they may be Tier 2 doctor tomorrow. If you get purple trigger, then consideration should also be given to whether a neonatal emergency 2222 call should be put out. This escalation doesn't hand over care of the baby, but steps should be taken by all members of staff to manage and address these concerns. The next section of the table then describes further escalation to what we've called a secondary contact that's expected when a review doesn't occur in the timely manner. It's all too common for staff to be busy or tied up with other cases, and in these situations, the concern should be escalated from the Tier 1 to the Tier 2 doctor or ANMP, and also to the shift leader. If they're also not able to attend and respond within the expected time frame, then the consultant should be called. Escalation should be in the form of an SBAR handover. As part of the NEWTT2 toolkit, we've produced an escalation record, which can be implemented as a sticker for paper notes or easily adapted into an electronic format. This functions both as an aid memoir and as documentation of events. The aim will be for this to replace and not increase paperwork, and we'll now have a look at how this would have worked for Matthew, who you met earlier. Yeah, so this is an example of the record, and it contains the date and time, the score itself, the level of alert raised, and then an SBAR section. The key bit in the recommendation is what the person has already done and what the action that's required and how quickly the review is needed. So, as you know, Matthew was born at 35 plus 6 weeks with a birth weight of 2.32 kilograms. He's now quiet and not waiting for feeds at 2 hours. As John has pointed out, this gives Matthew a score of 8, putting him in the red section of the escalation tool. So the red section is for a score of 6 or more, and Matthew therefore requires review by the Tier 1 doctor or ANMP immediately, and their Tier 2 colleague should also be informed at this point. So this would be an example of an SBAR format for how this may be escalated. This is midwife Jones calling about baby Matthew, who's in transitional care and has triggered on his first set of observations a NEWTT2 score of 8. Matthew was born at 35 plus 6 weeks, weighing 2.32 kilograms. He's now 2 hours old. He's quiet and not feeding well, with a blood glucose of 1.6, a low temperature and fast heart rate. I've wrapped him skin to skin with mum, and we're trying to get him to feed. Please come and review him immediately. Will you inform your Tier 2 or would you like me to? So that may be hopefully would be the conversation that would happen, and this could then be recorded on the NEWTT2 escalation record as I've mentioned. So here we'd have a date and time, the score highlighted, and the fact that an SBAR referral to the paediatric team has occurred. We can record the SBAR on this sticker. This could equally be done on a pro forma if that was another way to do. And that the agreed action is that there'll be an immediate review, and that the Tier 1 doctor has accepted this referral and will inform the Tier 2 doctor themselves. That can be dated and signed by the midwife. So thank you very much for listening, and I'm going to hand over to Kathryn now for the response section.
So my name's Dr. Kathryn Macallister, and as Wendy's already mentioned, I'm a neonatal grid trainee working in Bristol, and I was co-chair of the working group alongside Wendy. And I'm going to talk to you today about the response section of the deterioration of the newborn framework. So when we met as a working group, we first thought about what we thought was important about the response to a potentially deteriorating baby. And we agreed that the response should, of course, be timely in order to hopefully prevent further deterioration, but that we also needed to set targets that were achievable given the demands placed on healthcare professionals. So labour wards and postnatal wards are very busy places, and whilst in an ideal world, perhaps we'd like all these babies that are scoring to be seen immediately, that's not always possible, and we wanted to make sure the targets that were set were actually feasible on the ground. We also, as Oliver's mentioned, wanted to standardise the escalation and response process as much as possible, because we know that if things are use a standard template, then it tends to make them safer and to hopefully prevent errors. And we wanted to try and prevent the natural variation that occurs between shifts, depending on the personnel who are on and how busy they are, and to prevent some of the variation that occurs between hospitals and between neonatal networks as well. And we also all felt that it was really important that the response was carried out as a team. So a team that involves midwives, MCAs, neonatal nurses that might be working in transitional care, the doctors and the ANNPs that work on the medical rotas, and that all of these people should be working with each other, but also alongside the parents and the caregivers. And we wanted there to be this real feeling of a shared responsibility for all those people that were involved in looking after the baby and working together. So what's new in this new framework? Well, we hope those of you that have read it will agree that it does encourage a multidisciplinary response at every point. So it promotes collaboration between the different healthcare professionals and, as I've already said, a shared responsibility for the care of this baby, not a sort of back and forth handing over of responsibility, but an ongoing shared care for this baby. All of the framework, and particularly the response tools I'm going to come on to talk about, remind us to keep the parents updated and involved in the care at every point. And then one of the key features is there are 2 new response tools. So Oliver's mentioned the escalation sticker or escalation record, and one of the tools that I'm going to come on to talk about now is a review record, which would probably be used as a sticker alongside that escalation record, or if you want one document for both of those, then there's a joint escalation and review record. So these are new parts of the framework which are available to look at on the BAPM website as well, and I'll talk through them now. And they're designed so that they could be used as paper forms, or they could also be converted into digital formats for those places with electronic patient records. So this is the NEWTT2 review record, which we hope could be used as a sticker, or it could be used on a piece of paper, whatever would work in your trust. And this would be used after someone's reviewed reviewed the baby. So you document your review, and then you'd use this at the end as a way to document your plan. And it just provides a number of prompts to try and make sure that things don't get missed. So some of the key features of this sticker are that it again promotes that multidisciplinary team response. So if you've reviewed this baby, do you need to inform a senior member of your team? And also, in addition to documenting the plan, have you handed the plan over to someone, and who have you handed it over to? And I think that's a really key feature, because of course we'd all assume that we'd verbally hand a plan over when we've reviewed a baby, but in real life, again, the postnatal wards are busy. You often can't find the right person at the right time, and it's not sufficient to just write that plan in the notes. It's really vital that you discuss and hand over that plan to someone, that you agree on the plan going forward. So it's a prompt to remind us to do that. In addition, it again reminds us of parents, and that they're a key part of this team. So have we remembered to ask parents if they've got any concerns? And as John mentioned, have we asked those questions to actually make sure we elicit any concerns, and not just expected the parents to raise them themselves? And have we updated the parents with the plan? And are they happy with the plan? And also, this reminds us, in addition to documenting our ongoing plan, to think really carefully and document when this baby will next need a review, if it does indeed need a planned review, and how often does it need observations going forward. So if they're on 4-hourly observations, do they perhaps need them a bit sooner going forward, just to make sure that we don't miss any changes with this baby. This then is another document, so a separate document that is a joint escalation and review record. So the idea here is that this could be printed off as an A4 document, a double-sided A4 document that would replace any other documentation for this escalation episode. So you wouldn't need to write anything else in the notes, you'd just be as a team filling this in. And there is a lot of information here. It is available to look at on the website, but just to take you through it briefly, starting at the top left, that's the escalation process there. So this is what was on that escalation sticker, to be filled in by the midwife or person caring for the baby, with that S-bar handover and who they've referred the baby to. And then it goes on to include space for a review by a member of the medical team. So space to document the history, the examination findings, and then on what would be the second page of it, a list of potential investigations you might want to consider, space for your impression and your plan, and then also space for a further review of the baby moving forward. So if we just look in a bit more detail at this front page, again, what we hope this document really promotes is that shared responsibility for the baby. So the midwife or MCA would start off filling in this document, but then the medical team would come along and continue on this same form, working together to really work as a team to review this baby. And it's also trying to standardise this response process. We know that often the doctors that are covering the postnatal wards might be rotating around different jobs. They might be new to this particular role. We also know that whoever's carrying the bleep for the postnatal ward is often being pulled in several directions. They might be called away several times while they're reviewing this baby, perhaps, or they might have to go and answer the phone. So we really hope that if you were to adopt this record in your trust, it would help to make things safer by just providing those reminders of the things that are vital. So vital aspects of the history that you'd need to know, and vital things to consider for investigations moving forward. And that brings us nicely onto the reverse side of this document, where again there's that reminder of some investigations that you might want to consider. Yes, you're on the postnatal ward, but does the baby perhaps need to go to the neonatal unit for some tests, or are there things you can do at the bedside now that might help you decide which direction this baby's going in? Exactly the same as the escalation, the review sticker that we talked about previously. At the end of the plan section, there are a number of prompts there just to think about the ongoing plan, the frequency of observations, the handover. So again, it's really vital that the plan is discussed and handed over to the midwife caring for the baby, and also a reminder again to make sure you've updated the parents. And then there's also space at the bottom of the document for a further review of the baby, because in real life, it's quite rare that a baby's seen once and never seen again. You might just need to pop back later and check they've improved. You might be called back because they've deteriorated. And this hopefully just reduces some of the need to repeat all the documentation again in terms of sort of the history, and you can just document the key changes here. So that's a whistle-stop tour of those 2 new documents, and please do ask any questions about them. I'll be around to answer questions in the question and answer session at the end of the webinar. What I'm going to do now is I'm just going to run through another case using the whole framework just to show you how it would run through from sort of beginning to end for a particular baby. So we're going to consider baby Rose, who's a 38 plus 3-week baby that was born by a category 2 caesarean section because there was a non-reassuring CTG, and also the lichor was noted to be stained with thick meconium. So Rose made herself eligible for NEWTT2 observations due to the thick meconium, which is clearly documented in NICE guidance that she would need observations. And also she started to grunt at birth as well, so everyone was keen that she had observations going forward. So Rose had her first set of observations at 1 hour of age. So hopefully this isn't too small on your screens, but if you look at the far right here, there's a snippet of Rose's observation chart, her NEWTT2 chart with the first set of observations. And if you can just scan down that column, you'll see that most of her observations at this point are plotting into white boxes. So they don't score anything, they score 0. But about halfway down the chart, there's a little Y there, so a little yes for grunting, which plots in a yellow box. So Rose is grunting at the moment, but that's the only observation that's scoring anything, and that scores a 1 for being in a yellow box. So if we were to turn over our paper chart to look at the escalation table on the back, for a score of 1, if we were the midwife looking after the baby, we'd want to inform our shift leader at this point, and we'd want to make sure we repeated the observations within an hour. Again, if anyone was well, I think someone might, sorry, just have their microphone on accidentally. If anyone was particularly worried about Rose, then it's always suitable to call the medical team and ask for a review. Healthcare professional concern sort of trumps all of this if you were worried. But thankfully at this point, no one was particularly worried about Rose, so she continued on her observations, and at 2 hours of age, she had another set of observations done. And this time, if you just scan down this chart, you'll see that Rose is still grunting, so that plots in a yellow box. But also just below that, her heart rate has now gone up above 160, so that also plots in a yellow box. And down at the bottom, Rose's parents are now concerned because she's still making that grunting noise, so they're a bit worried, so that plots in a yellow box. So she's got 3 observations plotting in yellow boxes, which makes a total score of 3. And as per our escalation table, that means that in addition to informing the shift leader, you would want to refer Rose to the paediatric or neonatal Tier 1 doctor or ANNP and request that they please review Rose within an hour. So that's what occurs, and the Tier 1 doctor comes to review Rose, and actually at this point her grunting has settled, and so her parents aren't worried because she seems much better now. Her heart rate's also settled to within normal range, and you check her oxygen saturations because she'd had that respiratory distress, and her SATs are now 96%, which again is reassuring. So you discuss this with Rose's parents and with the rest of the team looking after Rose, and you all agree that Rose can continue on her NEWTT2 observations and stay with her parents, and that you can come and review Rose again if needed, or if she scores again on the chart. And you would then go on to document all this in the notes, and actually for Rose you've used that joint escalation and response record, so that the midwifery team have filled in the escalation section, you'd go on to fill in the response section. So Rose continues on her observations and things seem to be going well, but then at 12 hours of age, when she's having another set of obs done, Rose actually doesn't seem quite so well. She's grunting, she seems to be working hard to breathe, her parents are really worried, she doesn't want to feed. And as you look down this observation chart here, you'll see that a number of her observations are now plotting into yellow boxes. So she's got a slightly high temperature, she's tachypneic, she's tachycardic, she's grunting. Coming down the chart, her oxygen saturations are low at 92%. And Rose, all in all, has a total NEWTT2 score now of 8. So you'd refer to your escalation table, and that tells you that what you need to do is contact the tier 1 doctor or ANMP and ask them to please come and review Rose immediately, and to inform the tier 2 as well. So you actually decide to do that yourself once you've called the tier 1 because you're really quite worried about Rose. And the medical team come to review Rose promptly, and they agree that Rose needs admission to the neonatal unit. And once on the neonatal unit, Rose has a chest X-ray which shows signs that are consistent with meconium aspiration. But thankfully, she goes on to make good progress and discharges home breastfeeding. So that was hopefully a quick sort of whistle-stop tour of the new documents that are available to you in the response section of the framework, and also just showing you how the framework could be used in practice for a particular baby all the way through their stay on the postnatal ward. I'll now hand over to Hannah from NEWTT, who's going to talk us through the testing of the tool that's already been done.
Thank you, Kathryn. Hello, everybody. As I've been previously introduced, my name is Hannah Rutter, and I'm one of the Senior Improvement Managers with NEWTT. And I have been privileged to be part of the working group for the last 2 and a bit years, and myself and Tony Kelly have been very much leading on the improvement testing of the NEWTT2 tool. And I'm hoping that some of you on the call this afternoon have very much seen and been part of that testing. And what I just want to highlight at this point is that the work has been led by NEWTT in the national team, but actually this has been a truly collaborative effort with our patient safety collaborative colleagues within the AHSN networks. But actually what I want to really acknowledge at this point is that the organisations that have given their time to partake in this testing, it's no mean feat to actually be able to free staff up to support national work. So my gratitude to those organisations and individuals that have been part of the testing. I am going to give you a little bit of an overview. Like I say, 2 years is a long time, and this will be a very high level overview of the testing and the sort of methodology that we use to come to the final draft of the NEWTT2 document that you have seen already this afternoon. So I'm just going to go through what those testing phases look like, the design phase, phase 1, phase 2, and actually what our considerations are now moving forward into the implementation phase of NEWTT2. So the testing phases. So we began this journey very much looking at the 2015 NEWTT that was already being used across England and our devolved nations, but then wanting to understand how we can actually make this tool better, and actually the adoption and spread of the original NEWTT a much more sort of like collaborative effort across the country. So we embarked on a number of community consensus building exercises and prototyping exercises to know that the draft tool that we came up with for the working group was actually something that had been really sort of based in the sort of ground and shop level sort of area, so that actually we've taken a lot of clinicians on this journey with us to ensure that actually how this looked was actually how it would work in practice. We then moved into sort of phase 1 of navigating the tool. So what we really wanted to understand from that was what the usability of this tool was like, and what the language was like, and if there's anything that needed to be changed in terms of visualization and the language that had been attributed to both the front of the chart and the back of the chart. Then we moved into our phase 2 testing, which some of you may have heard as pilot testing, and this was very much using the tool alongside in our organisations those babies that were on the tool in their organisation that's covered by their governance structures, alongside our NEWTT2 tool, to see actually if there was anything that was coming up as a red flag that we needed to address, or that actually what the design that had come right from the sort of ground up was actually robust and fit for sort of dissemination across all services. And then moving into our implementation phase, which is the sort of like next big piece of work and the most exciting piece of the work, really actually using this tool in real life practice. So just a bit about the design. I've already alluded to the fact of the collaboration with our patient safety collaborative colleagues. What I wanted to highlight here is that they are extremely adept at communicating with the system, and through their patient safety networks have been able to support the engagement pieces that we needed along the way. and have very much been the key contributors to ensuring that we had engagement with consensus building, the prototyping of the chart design, the thresholds and triggers table, the implications of what the chart design were and were not to be as we move forward, but also trying to sort of capture what our future adoption and spread could be like with NEWTT2 through capturing sort of like a digital maturity picture, so that we understand where we need to be focusing our efforts for paper-based organisations, and actually what the degree of digital capture is across the country, so that we can actually start aligning what this could look like at pace as we move through into implementation. I just wanted to give you a little bit of an overview of the sort of phase 1 and phase 2 testing results, starting in phase 1. And actually this phase was the very first sort of like baby step phase of NEWTT2, whereby we wanted to utilise organisations that were paper-based. We had to go with the paper-based organisations because we wanted to think through what alongside testing would look like, but also what early adoption would look like of this tool. And actually, we had 12 paper-based organisations identify themselves as wanting to really be part of this process. What we asked was for each of the organisations to utilise 10 cold cases, so pull on 10 sets of baby notes, and to sort of run those observations through the chart. And we had set up an online survey for responses to come directly back into the NEWTT team, but on the side of that, completely confidentially, sending the completed charts back to the team so that we could actually see whether the interaction had been good and whether the scores had been added correctly, and actually what that escalation looked like on the shop floor. We were really pleased with the 54 charts that were returned to us and the questionnaires also, and actually had 248 sets of observations recorded. So from a data set point of view, and actually trying to understand what that would look like, was a really robust sort of set of observations that were returned. And actually sort of the overall completion of the chart, bearing in mind we didn't have a full training package at that point in time, and it was very much sort of cold cases, the overall completion of the front of the chart was exemplary. It was very good, and just gave us sort of a little bit more intelligence to move into the next phases. I must say at this point that at every step of the way, after each sort of testing phase, this has been very much reported back to the BAPM working group so that we can make decisions, make agreement, and move on into the next phase of testing. Phase 2 overview, sorry. So this was the using the tool in practical settings. So alongside the governance already in place on the tool that's being used, we asked for this tool to be used alongside and for observations to be plotted at the same time as so on 2 tools. So I hope you can appreciate that was quite a big ask of our organisations at a time where we know that it's very busy and the sort of staffing levels. So we just wanted to ensure that we were doing this in as practical a way as possible for those organisations. And we were really heartened to have a significant number embark on this testing process for us. And actually this cross-section of healthcare professionals, we really wanted to be hearing from those midwives and maternity support workers who would be using this tool on the postnatal ward predominantly, but also from other nurses, staff nurses and nursery nurses that inputted into this testing phase for us. The results were wonderful from the phase 2 testing phase. We had 64 responders, and actually of those 64 responders, that tool had been used for 181 interactions. So there'd been 181 separate interactions on those tools during that testing phase. And we really wanted to understand if there was any difference between sort of night shift and day shift, and actually what day of the week. So we'd really asked for the organisations to think about how they could plan this out so that we had an overview of what that looked like. So we did have 54 day shift responses and 10 night shift responses. So we did have, although more day, we did have some clinicians using this during nighttime hours, which was really important to understand whether there was anything that we needed to tweak based on different times of the day. I just wanted to just showcase some of the wonderful feedback we had from our user organisations. There's far too many on this screen to go through individually, but the one thing that is quite new for some people, is moving from a score from a colour-based escalation, so a red or 2 yellows and a red, to formulate the escalation, actually moving to more in alignment with other early warning scores, i.e. NEWS and MEWS, and actually thinking about how we score against the sort of vital signs that are being documented. And actually we're quite heartened to see that it was easy to navigate, that actually the total score was well received, although there was very much we need a little bit more training on this, but the total score was well received. The parental concern was a new inclusion and very much well received by our organisation testers, and just an overall great chart. But there is no point in providing you with the good information without actually just recognising that there was some sort of like not quite so good feedback. So wonderful feedback tempered by a little bit of things that we needed to consider. And that is absolutely what we want out of any testing phase. We have to consider the good, the bad and the ugly. And we had to think about whether we had been clear, whether our scoring was clear, whether the chart was clear, in order to reach this wonderful stage today of launch and publication of NEWTT2. So all of the sort of tentative feedback was taken back to the BAPM working group, and we've worked through that systematically to ensure that we have heard any sort of concerns from our clinical community. We've actioned those concerns, and also through the sort of framework, through the, I can't remember the word, it's absolutely gone from me. We've actually identified and acted upon any of the sort of like feedback that has come back to us from our users in the organisations. And moving into implementation, that word is really easy and trips off the tongue really quite well, but actually there's a lot of work to now implement this across England, so that we are, as our colleagues have said previously in this call, the whole idea of this is to provide standardisation and reduce the sort of variability across the whole of the country, which actually, when you do a deep dive diagnostic on all early warning scores out there, particularly maternity early warning score and the newborn, the variety is huge. And actually we need to think about it from a patient safety point of view, and actually what standardisation and sort of making sure that everything is the same across the country is as much as we can possibly do. So moving into implementation, we need to think about that. But we also need to think about what the future of the digitalisation for NEWTT2 looks like. And I know that Tony will be talking to you about that in the next sort of slide decks. We are already starting to work with our Health Education England colleagues to bring together an e-learning package, so support organisations to actually robustly go through the training. But none of this will be done in England without the support of myself and Tony Kelly as the NEWTT national team, but also with our patient safety collaboratives out in our sort of academic health science networks through their patient safety networks. So everything will be well supported, and there will be support for those organisations moving through, particularly in the early phases of implementation. I'm very grateful for you listening to me. There is some slides there there's a slide there that will be shared with our contact details on, but now I have the great privilege to hand over to my colleague Tony Kelly, who can introduce himself, and thank you for listening.
Thanks, Hannah, and thanks everyone else for what I hope everyone's finding to be an interesting overview of some really important work that's been going on over the last couple of years in this space. I just wanted to add my thanks to all the people that have been in the working group from BAPM, because I think what we've ended up with here is a really impressive piece of work, which I hope will be supportive in improving the quality of care that we can provide to these newborn babies. There's a couple of things I just want to sort of run through with you, which some of you may already have been thinking about while you've been listening to this presentation. Han, can I have the next slide? One of those is really the challenges that we face across the country when we look at the differences that we have in the systems that we're using to provide care. And we are currently in a relatively digitally immature environment within the NHS in England. Recent digital maturity surveys across the country looking at maternity and neonatal services have been quite variable in the responses that they've got. A number of organisations will have disparity between whether they use systems like the neonatal badger system for a full EPR, whether they just collect data on it. And then there may be multiple systems in organisations, but different maternity systems, different systems for collecting vital signs, and not necessarily full alignment between the maternity systems and the neonatal systems. And all of this will make that move into a full digital record and a full digital system in our organisations much harder. One of the things that I'm sure you're all very mindful of is the majority of this kind of care, in the sense of using this tool, will be based within maternity systems. And then the ultimate admission for these babies, if they do end up needing to go to the neonatal unit, would then move into neonatal systems. I work in a hospital in Sussex, in Brighton, where we have got both neonatal and maternity badger, so that allows that sort of handover between care spaces much easier. But in a number of organisations that won't be the case. The biggest challenge we face in this area, however, is the fact that we don't have any defined national specifications at the moment for our early warning systems. I work also with Hannah on a programme where we've developed a new national maternity early warning score tool. And both that tool and the new NEWTT2 tool will be having national digital specifications developed in the late spring. These will then be used to support and inform all of the providers who are providing sort of digital maternity information systems for how they need to be providing this information within their systems, so that we've got a uniform way in which the information is presented, and also a uniform way in which that will assist and support clinical decision making in the workplace. So that process will be ongoing during this year. We hoped it would have been accelerated and would be finished by the end of the spring, but for a variety of reasons that at the moment isn't going to be possible. And that will allow us to get a bit more digital maturity and a little bit more consistency within and across organisations within systems. And this sort of multiple system issue is going to become increasingly taxing, although many of you as neonatologists will be very used to using CleverMed systems. The variety of systems you use in maternity is much more varied. Once we've got these digital specifications developed, we are then going to have to do a little bit of testing again, because the challenges that we will face in the digital environment will be slightly different to those in the paper-based environments. And some of what Hannah has already presented, we will have to do as we move along. And we will be looking to a number of organisations to be open to doing that testing process. And there'll be a lot more information coming out about this into the system over the next couple of months. So hopefully we will be able to give you a little bit more detail on that as things move forward. And really what we're hoping to be able to do then is provide sort of end-to-end care. So we don't have these breakdowns between the way that we are providing care as either paper-based moving into digital, or from two different digital systems, without there being an easy way for them to communicate. The timescales, unfortunately, are a little bit fluid, but our anticipation is that we will have these digital specifications available as we go into the early part of the summer, followed by a short testing phase, and then hopefully the digital organisations will then start being able to adopt and implement this framework as we move into the autumn. Some of the challenges, as well as just the systems themselves, is how we capture the information, and some thinking slightly about some of the hardware solutions that we faced, as well as some of the software solutions. There are some interesting innovations depending on how you look at the range of systems that are in place currently that employ early warning scores or early warning tools in their systems. Some of them are very static. The information can be entered or pulled across from observations. A number of the fields in this tool will need to be manually inputted, because they won't be necessarily automatically pull across in the way a blood pressure or a pulse may well be. But then really the advantage of some of these digital systems, when we get them right, is they will provide some clinical decision-making support. So if you have a score of 3, a score of 5, or if there is a critical observation that is present for that child, then it will actually give you information about what needs to happen and by when. You would then be able to track whether those responses are happening. And in some systems that we've got currently in use, depending on the hardware that's being used, some of those alerts can be sent directly to healthcare professionals who are allocated to be receiving those messages during that day. Now, obviously, some of that very fraught with problem, depending on how stable our workforce is and people covering, but it does allow the potential for much greater decision support, and it does also allow for us to be able to rationalise the way that we alert and escalate our care. And ultimately, as we move into the sort of the slightly more interesting space from digitalisation, at the moment, what we're doing is taking a standardised paper-based tool and converting it into a digital version of that tool. So you're using thresholds that are predefined. When you start moving into using AI in these spaces, then actually it becomes a lot more exciting in the fact that there's a much more fluid sense of looking at changes that are happening in real time in a number of those, particularly for those with the continuous variables like pulse and blood pressure and temperature, so that you're not necessarily waiting for a threshold, but you're looking for trends in the combination of those observations. And certainly some of the work we're doing in the maternity space is starting to see how we can use AI technologies to start looking at big data sets of information to understand how we can create some of these algorithms that will support our care as we move forward. So that's kind of a brief overview of where we are in the digital space. So we're very much aware there's a lot to be done here, but it's work that's in play. We've got plans to move that forward. And so all of you who work in organisations where you've got digital solutions at the moment, we will be there to try and support you as we go through the summer. Can I have the next slide, Han? But then I think is one area that is worth us being very open about and really telling you about what we're aiming and planning to do. There is a real paucity of information out there about most early warning scores. Most of them have been developed traditionally using consensus. Certainly the National Maternity Early Warning Score we've developed now is the first one that's been based on population data. And because of the paucity of data, it's often very difficult to develop them in a way that feels robust. I feel very confident in saying that the way that this tool has been developed has built on the initial work from the first framework, has used a very robust approach. And one of the elements that's already been done is taking a large digital data set and applying this new tool with the new cutoffs to that data set to see how it performs in the sense of how often it's alerting and how it will sort of hold up if it was being used in prospective clinical practice. And I think that's something that's really important, and that data is available. But I think moving forward, what we've got to do is look and see whether we understand how this will work. So we're lucky in the fact that it's a small, concise group of babies that we're going to be looking after in one particular clinical area. And the ultimate outcome for these babies is whether they get admitted to neonatal units. So we will be able to track this a little bit better. We are having conversations with CleverMed on the way that we'll be able to integrate some reporting you'll be able to do on a local level. And ultimately, I think what we should be moving forward to is actually understanding the reasons for the admission rather than just whether the admission took place. And then we're going to look to try and do a mixed methods evaluation moving forward to look at both the quantitative impact of this work, but also qualitatively to understand how it affects the teams who are providing the observations, but equally hopefully the benefit rather than the disbenefit to the parents of these babies, because ultimately what we're trying to do is identify the babies at risk, but clearly keep them with their mother at all times where we can. So I think that's something that again will evolve over the coming months, but we didn't want you to think that this wasn't in our eye line as something that was definitely going to be done as we move forward, and where we need to reevaluate what we've already developed so far. So just a quick overview, and thanks very much for listening, and look forward to some questions. Thanks very much.
Thanks, Tony. Hannah, if you just unshare your slides, I'll share my last slides just while you're all preparing for the Q&A. So I wanted to share with you the data work that Tony has just alluded to. Thank you ever so much for that. So it's just coming into its PowerPoint. There's always a delay on these things, isn't there? We are running a little bit over time, but I think we've got time to do this while we are waiting for your comments to be and questions to be placed in the chat. So I want to introduce you to Amapal. Amapal was a registrar when he started with us, but as you've heard, we've been almost 2 years on this working group, and Amapal is now a consultant, but he did a lot of work for us in the units in which he was a tier 2 before his consultant appointment. And his unit gave permission for him to be able to source anonymously data sets through BadgerNet. So he did a retrospective data extraction. And whilst we realise there are limitations for this, the validations that have occurred over the world with various tools are usually of small numbers, and they're usually retrospective. And as Tony's alluded to, we wish to build on that. So the retrospective data collection, and this is for a whole year in a very busy neonatal intensive care unit setting, consultant units. Now, in that particular hospital, the babies were placed onto the BadgerNet charts at 4 hours of age. There's a different chart that uses prior to this. So one of the limitations of this study is that it excludes babies that are less than 4 hours of age and those that are admitted in that early phase. But really, maybe that means that then we're focusing on the babies we really want to look at, those with a disordered or delayed transition or early signs of illness. And as in all validated tools that have been published, we looked at neonatal unit team attendance to review the baby and neonatal unit admission. And poor old Emma Power had to look through 43,811 data points, which just sounds huge. And we're very indebted to him. And he found that there were 139 scores, and they were in the range of 1 to 5 or a purple score. He looked back retrospectively to see all the infants that contributed to those scores, whether they were actually seen by a neonatal team member, and they had. So all infants that scored 1 or more had already been seen. So looking back retrospectively, we're not asking the neonatal team to do any more, or the paediatric team to do any more work over and above that they were already doing, just formulating and standardising the approach. And of those babies, there were 27 admissions, 23 of whom were term 37 weeks or greater. And what was reassuring is they all would have triggered. So we would not have, of all the admissions in the year, not the babies that made a score, so all of the neonatal admissions in the year, there were 27 more than 4 hours of age. And all of those would have triggered NEWTT2. And in that particular unit, the reasons for admission were given here for cyanosis, respiratory, but also a significant proportion of hypothermia. And this is one of the things we're really hoping that NEWTT2 is going to help with that hypothermia prompt that John told you about. If we can get in early management for hypothermia with thermal care, can we actually avoid those emissions completely? So Tony, sorry, has already talked about this. I have to say the physiological ranges evidence out there on which early warning scores are based is really very limited in the newborn, and does not really reflect the differing gestational ages. And that's an issue in a massive area of research, which I don't think us as a team can take on, but is definitely there for taking. And as Tony has said, we need to know what the parents and the staff think. We need to know if we're picking up the right babies or too many babies, and whether, as I say, postnatal ward interventions such as the management of hypothermia can avoid admissions. Are we picking up the babies that we really need to earlier and getting treatment in sooner? And as Tony says, is there a way of comparing outcomes where these tools are followed and where they're not followed? So I'm going to stop presenting now, and then I'm going to invite the panel to turn on their screens, and I'm hoping that we're going to have some questions. So on the panel, you have all the people that you've heard speak already, but we're also inviting Shalini, should you have any questions from her survey, and also Emma Powell, if you have got any questions about his data extraction. So over to you, Kathryn, for the first question.
Thanks, Wendy, and thanks everyone for your presentations today. I thought there's a couple of questions that have just come in about when the framework will be published, and the answer is that it actually went live on the website today, so it is available there for you to look at. But then questions about the implementation of the framework, and I wonder if perhaps Tony or Hannah could just talk about the support that will be available to trusts for implementing this. And there's a specific question about whether those trusts with electronic systems should be waiting until the autumn to implement it when the digital guidance comes out.
I can talk to the digital thing. I think Hannah's probably better placed to talk about the actual support. So we'd ask, the easy answer is wait. We will know a little bit more in the next couple of months as to what might be other options. The difficulty is what we would rather have is a standardized tool structure across the country. And clearly the way some of these systems may incorporate that tool into the way that, literally down to the coding that they might need to actually make it appear will be very different. We want the actual external version of it and the functionality of it to be the same across the country. So having those digital specifications will allow those providers to do that more easily. And it will be easier that we've got those specifications developed to allow that conversation to happen once across the country. So that would be the easy answer. The other way of looking at it is we may look to find a number of digital providers of these maternity service solutions to do some of the early testing and development over the next few months with some provider organisations to see how that process works, because we're just conscious that we need to move on. Otherwise, some organisations are going to have to wait a number of months. But most of that information will come to you either via your maternity information system provider or via your patient safety collaborative support, which Hannah is now going to talk about.
And I'm glad you took the digital question. Thank you, Tony. Any paper-based organisations in England can access support via me, who can then direct you to your local patient safety collaborative. So we would want to start thinking about what that implementation looks like in your organisation. So whether you need to change any governance structures, what training implications that would mean for your midwives and maternity support workers, neonatal nurses, etc. So the framework is published, it can be implemented, but what we really want to do, as we have done all the way along, is really to truly support the implementation so we can understand as we move forward and learn from you what the good and the bad looks like when it comes to actually sort of changing from one system to another system, and what implementation and equally de-implementation looks like as we move forward.
Thanks,
I hope that
Hannah.
makes sense.
Yeah, thanks, Hannah. And also we are seeking to ensure there are links in the devolved nations. The BAPM obviously is a UK organisation, so the office is actively seeking links for Wales, Northern Ireland and Scotland also. I was just
Wendy,
going to, yes?
Can I just jump in on the digital thing? I suppose, Tony, the challenge is people have currently got a chart which may or may not be based on old NEWTT, and we're now saying we've now got new NEWTT2, which we're saying is better, but don't use it. So I don't think anyone would be telling anyone not to use the new ranges and escalation criteria if you've already got an electronic observation chart, which many organisations will have.
Thanks, Oliver. So
I don't know what you think of that, Tony.
Can we come back to that? Is that all right? Just wanted to, we've got a little bit of time left. And I just wanted to make sure we got through all the questions. So if we have, and that gives Tony time to think to answer your very good question there, Oliver. So Linda Poulter from Cambridge, earlier on in the webinar, she actually put down the first question, and she's quite rightly explained that SBAR has now been upgraded to SBARD, which made me smile, and that's just a reflection of how long this framework has been in writing. But I was going to ask Kathryn if that's all right, because I think the D is for decision. I think maybe your multidisciplinary review and tools actually have decision making within that. What would you say?
Yeah, so I saw that question come up actually, and I was thinking that whilst the tool doesn't formally add in the D for SBARD, for those who aren't familiar with it, the D adds in a decision-making section at the end. And I think that if you were to look back at the escalation sticker, which Oliver showed, that does have a sort of a space to document that you've agreed on the plan with the person that you're referring to, and that they've agreed to come and review the baby within a certain time, and if there are any actions needed in the meantime. So I think whilst we haven't formally added on that D, it definitely is encouraging that team approach to the decision making and that agreed plan moving forward. So whether it's something that in another iteration of this framework, maybe in 20 years time when we get to that point, might add that in, but I think for the time being we've sort of done it without actually having that D written there.
Thank you. And because I've given you that question, I've got ready with another one now, if that's all right, from Fiona. She asked us a very interesting question. She asked a question about why we're not considering using these tools for neonatal surgical neonates. And that she was hoping for an early warning school for this population. And now these babies are on a neonatal unit. And is there any plan to have early warning schools for neonatal units ongoing? Now I don't really know who I'm going to direct that to, but I think to start with I might ask John, because John is the person here with the most historical knowledge about the use of the current early warning score in it as it is.
Thank you so much, Wendy. I think it's about understanding what the baby is, not where they are. And the original charts were developed to assist in the triage and the understanding of whether babies on the postnatal wards and in labour ward were unwell, potentially unwell, and potentially getting worse. And as far as transitional care is concerned, they're very much the same babies. And to some degree, you could argue that those same babies do exist in special care baby units, but there's an overlap with another population of babies who might not then apply to the chart. So it's a common sense approach for me. The chart is not designed, for example, for babies with low level respiratory support on oxygen. It would confound saturation monitoring and things like that. But nevertheless, it's still an escalation chart. So it's not excluding it from those areas. It's using it with intelligence, as far as I'm concerned. And you need to be aware of that. So the main specification is for postnatal babies of late preterm term, and they exist in other domains. I mean, the same could apply, and I go out on a limb here with the question around surgical babies, because they are also babies of a certain type, and it's up to those who are using the chart to understand how they're using it, and that is risk management. And we can't cover every single eventuality with a single tool. I think the bilirubin thing demonstrates that very adequately with stratified charts for differing ranges for differing babies. The physiological ranges on this chart are, as best with best intentions, reflect those of the population of babies it was designed to apply with. And you can argue the toss around the edges of those ranges because it's fuzzy logic. And if you look at the published ranges for normal ranges for babies, they vary as well in the different papers. So it's a sort of, it is fuzzy logic. Around the edges of this, fuzzy logic applies. It's not black and white. There are areas of grey, and you've got to use it in an intelligent way. So the answer is yes and no.
Thanks, John. I think one more question that we can hopefully just answer, well, I was going to say quickly or give a time frame for is, and again, another question, but probably for Tony, about when will the HEE training package be available? So I know that work is just sort of beginning on that, so I imagine the answer is a little while, but have you got any sort of time frame at this point, Tony?
Actually, I'll need to ask Hannah because I can't remember the exact time that we were going for.
We were hoping for the NEWTT2 e-learning to be ready sort of April. So they have 3 big pieces of work for us at the moment, and they're working through it systematically. They have all the materials now to start working it up, so it should move quite quickly.
Thanks, Hannah. Kate has kindly put a link in the chat for the support for the devolved nations, should you have any queries about the implementation in those countries. Now, there is another question also about early warning scores for neonatal units here, Tony, and it does say, is there any intention to carry this forward and develop a version that works for intensive care neonates? I don't know whether NHS England have got any plans. I thought we were on a perinatal package that was to do with maternity, the fetus and the newborn, as opposed to older children on a neonatal unit. I wonder if you've got any comments about that, if any.
It depends if you want me to scuppy Bapham in the conversation, because I think it's definitely something that needs doing, personally. I think we look at the suite of early warning score tools we've got. So we've got the adult non-pregnant, we've now got the pregnant. Pews is moving along quite nicely, and the gestation, the age related differences that you need on those parameters has been something that has been really challenging for that group. But again, if we're moving into an environment of more digital maturity, I think that becomes less of a problem. The patient safety issues is moving between making sure you got the right paper tool for the right baby or the right neonate. I think if you're doing it in a neonatal environment, I think there's an opportunity to do something very exciting, but it's a big bit of work. It's not to be underplayed, considering the impact that the interventions that you use in those neonatal spaces, I can't believe I'm saying this in front of a load of neonatologists, but how that will affect your ability to monitor the deterioration of that baby, I think is really very challenging. But I think it would be a great thing to do. Is it something that we at NHS England will be doing in the short term? No. We've got so much that we've got to land in the next couple of years that I think the focus is on reducing stillbirth, reducing neonatal death, reducing brain injury. That they are big ticket items at the moment. So I think it would be something that would be really exciting to be involved with, but it isn't something that I can imagine we'll be doing soon.
No, maybe when digitalisation has been complete for this, then that's the time to start, because you've got everybody on a digital system in a neonatal unit. John, are you coming in with a comment on that?
Yeah, I was just going to say that a point Tony raised, and it was one that was massively obvious when we started this work, even in 2010, and weirdly still in 2022, is the lack of evidence. It is so. It's quite. I don't know where to start, but the fact is we're guessing along the whole of this system. The chart itself is guesswork. And Tony's point about using the chart and beginning to get some evidence to validate the scales and to validate the responses, I think is vital, because that then informs any change in the parameters of the chart and would inform any change or proposed change in population. So things like charts for intensive care, charts in other areas, should be evidence-based around our understanding of what are the accurate ranges and what are the domains which actually genuinely trigger. This is best intentions. We're guessing as to what the domains are. We're guessing as to the trigger levels. Maybe in a year or two's time or more, when we've got some information, we'll be able to revise the chart on an evidence base.
Thank you. That's really very clear, actually. Kathryn?
Yeah, so a question that I thought you'd be best placed to answer, Wendy, actually, just about that we've mentioned the chart can be used for monitoring babies where mothers have been on psychotropic drugs, and is there a recommendation for how long those babies should be monitored for? So I know you looked through a lot of the literature and the guidance out there on that.
Yeah, good question, because there isn't really. The nice guidance for maternal SSRIs and SNRIs recommends neonatal monitoring, but it doesn't say for how long. We haven't stipulated that a duration. I think you could do 4-hourly monitoring. The reason I think for they haven't is that it is an individual approach, because you may have a baby that's been exposed to a single agent. That's very different from someone who's been exposed to multiple combined treatments. In my local trust, we did very brief monitoring for babies that were on mothers who were on single agents, such as an SSRI, and they were also allowed to deliver in a community birthing setting. But for those on a combined approach or high doses, then their monitoring would have been different. So I think it's quite individualised, very hard to answer, and I can see why it's not in the NICE guidance as to an exact duration, because it depends very much what those maternal medications are and what the combination of them are. So we'd have to leave that with the local teams, I'm afraid.
Thanks, Wendy. I've just had a little scan through the questions, and I think, there might be some new ones coming. I think we've answered most of them so far. There are a few people going into the sort of specifics of electronic patient records, which I think is a little bit beyond me, and I think you're sort of answering those yourselves in the chat. And I'm aware that we are now hitting 3:30, so it probably is time to draw things to a close. But just one last call: if there are any further questions, you could pop your hand up now or pop them straight in the chat. But I think from what I can tell, we've answered most of them so far.
There's one about blood glucose, and I'd just like to say that if a baby's on NEWTT2 charts, they do not all have to have a blood glucose. They only have blood glucose measured if they fulfil the need to do that for the BAPM hypoglycemia at risk guidance, or as Oliver presented, when you turn over, they've got a score of 1 and you want to consider that, or for any baby, of course, who has a change in feeding, a deterioration in their feeding, sorry. Is that all right? I just spotted that one. It came in at the end. Now, if there are any questions that have not been answered, then we'll do our best to download the chat and get those responses to you. I'm sorry that we didn't have any questions for Amapal and Shalini. I'm very grateful that they've joined us today. Tony, are you going to answer Oliver's question just before we finish? Can you remember what it was?
Yeah, no, I can. I'm just not sure. I think it troubles me a little bit. So I think the problem that we have is the idea that you would have an electronic version of a tool from the previous framework, where you're asking people to then interpret that tool with new parameters and new additional implementation, and that would be a bit odd. But if that's not what you're saying, then I don't understand your question. So I can't answer it.
It's probably for the next webinar, I think, isn't it? I think, like Kathryn says we're getting into fine detail there. Someone has just put a question about when should people start using this tool, though.
They can start using it today if they wish.
Yeah,
It's all
I just
available on the
I just thought
BAPM
that was a good
website.
question to ask. You don't have to wait for training. From the training is available. You don't have to wait for it. You can do it in-house.
Yeah, and then we've got some final detailed questions about over triggering. Just remember, if you have a score of 1, that is not an immediate escalation. That just it's just an early warning that you might need to do something else. So do not worry too much. We realise again this has been mostly based on consensus and the survey, and a literature search of all the tools in the world that are available, and we've tried to be as consistent as we can. We may not be perfect, but we need to start using the tool and then have ongoing validation so that we can adapt it as
Wendy,
whether
can I
things or not.
just add another comment to support that, which I think
Yeah.
might be, we were having this conversation the other day, because the whole idea is that the clue is in the name for these tools. This is about early warning, and early warning, it does not necessarily necessitate treatment. Early warning is about understanding where the risks are, having a conversation, and a lot of the time this involves the opportunity to prevent deterioration that may occur. And a lot of the time what we end up thinking about is late warning, which is often then moved into the point at which you've got to do rescue. And so actually being informed and having conversations doesn't necessarily require you to be doing something for that baby or admitting it, but it may actually offer an opportunity to prevent problems downstream. So yeah, we've just got to find out how this plays out, but I think it's going to be a fantastic opportunity.
Thank you, Tony. That's really helpful response. So I can see that we're losing participants, and as Kathryn says, we've gone over our hour and a half of the webinar. I just want to thank everybody who's joined the webinar, everybody who's going to be watching this at a separate time, and all of the speakers and all of the working group. And as a last plug, as a recent treasurer for BOPM, if you're not a member of BOPM, do consider joining the British Association of Perinatal Medicine, because together we are stronger.